In Unit 8, we will discuss pre-transfusion testing, and I apologize for my voice. I have some kind of upper respiratory bug, but this is part 1 of 3. The purpose of pre-transfusion testing is to select for each recipient blood components which, when transfused, will survive and not cause destruction of the recipient's red cells. We must prevent transfusion of incompatible donor cells, which may cause a hemolytic transfusion reaction, an HTR. The U.S. federal government regulates transfusion services by giving authority to CLIA to oversee testing. The minimum testing that must be done is the ABOD type, both forward and reverse, antibody detection, and if that's positive, antibody identification, and then the last part is the actual compatibility testing. Pre-transfusion testing includes many specific requirements. And once again, you cannot on your own decide, well, I'm just not going to check the patient's history or not do one of these steps, because then that could lead to an acute hemolytic transfusion reaction in the patient. Positive identification of the recipient and the recipient sample. So this is done physically by verifying patient information, then without error labeling the sample tubes. Review of transfusion records for previous results. We'll talk about the importance of this, but if you have a history on a patient, that kind of gives you a jump start whether or not you have a problem or not. Test on donor blood. These are done at the donor center, but there are some tests that must be done in the transfusion service. You must perform an ABOD type on the recipient, antibody detection using serum or plasma from the patient. You must select ABOD appropriate components. For example, we've spoken that in an emergency situation, group AB plasma is the universal donor. But if you have time and you have a type on the patient, then we go with type specific. You want to test the serum or plasma with the donor red cells. This is called a major cross-match, and we'll talk about the different ways this is done. And then ultimately, once all this is done, appropriate labeling of the donor units. Modern transfusions are usually safe and beneficial. Donor or recipient red cells may undergo accelerated destruction due to the presence of an immune antibody. And again, an immune antibody is an IgG class that reacts at 37 degrees. Most hemolytic transfusion reactions are caused by errors in patient or sample identity. And probably 99 times out of 100, somebody drew the patient, labeled it with the wrong patient information, and then we don't know in the transfusion service whether or not this has happened. So we rely on the label on the tube of blood to be correct. Otherwise, unfortunately, if they are not the same type, if they're an incompatible type, they may undergo a hemolytic transfusion reaction and die. The antibody may be below the level of detectability. Remember, we have our primary and our secondary immune responses, and in the primary, the IgG antibody may fall below the level of detectability. It's still there, but our test systems are not sensitive enough to detect them. Even when everything is done absolutely correctly, we cannot guarantee survival of transfused cells. There are only 3 things that, if properly performed, pre-transfusion testing will do. Number 1, ensure the patient receives the correct components. Number 2, verify in most cases that the components are ABO compatible. On immediate spin, you're going to know that you accidentally picked up a group A unit instead of a group O unit, because you're going to get 4+ agglutination. And then number 3, detect most, not all, most clinically significant unexpected antibodies. And remember, an unexpected antibody are those other than ABO. Modern blood banking practices have undergone many changes over the last 40 years. During the 1980s, the time came for eliminating unnecessary tests. When I first entered the field, oh my gosh, we had probably 40 tubes for every cross match because we were so concerned about detecting any antibody which reacted at any phase of activity. We even worried about donor plasma antibodies that may be directed against patient RBCs. So again, you are so lucky that you have, you may think it's a massive quantity of tubes, but it's half the amount that was required in the 80s. The ongoing reevaluation led to streamlining procedures for cost effectiveness and patient safety. What is the likelihood that there's enough plasma present that even if there was an immune antibody present in donor plasma and the patient was positive, what were the chances that that would lead to an acute hemolytic transfusion reaction or red cell destruction? Slim to none. So we started working smarter, not harder, and always with the patient's safety in mind. So this intelligent approach requires rigid adherence to the guidelines and standards that exist to this date. The changes were based on, number one, patient safety. Number two, elimination of unwanted reaction. We used to have to set up 2 sets of screens. One was incubated at room temperature. The other one, we had the enhancement reagent, then it was incubated. And guess what we saw in immediate spin? We saw room temperature reacting antibodies, which were 99.9% of the time clinically insignificant. They were just problems. And then increased speed of testing procedures performed. We went away from albumin and we started going with low ionic salt strength solutions, or even we're going with solid phase, which we will talk about. So we have made a lot of changes to decrease the amount of time to the extent possible to get our blood products out to our patients. The transfusion request form can be either oral, electronic, or written, and must include information sufficient to positively identify the patient. You say, oral? What do you mean oral? Well, I get a call from the OR. They give me the patient's name, their ID number, and they order the blood. Now, it's followed up by a written order that's put in the computer. But yes, if they call me from the OR and say, I need 2 more units on this patient, I'm going to cross-match 2 more. The patient must have 2 patient identifiers required. The patient's full name and some unique number. Another identifier, such as a date of birth, a driver's license number, or a photographic ID, may be required for outpatient procedures. But most institutions, when you have an inpatient, it's the patient's full name and their unique ID number, usually their medical records number. Blood is considered a drug and requires a physician prescription. And we have received in the transfusion service on an outpatient basis, the patient will provide us with the prescription written by the doctor. Additional helpful information that may be on the transfusion request form is the sex, whether they're male or female, their age, because if I do have serological problems, their age may be a clue. For example, the very, very young and the very old may have weaker ABO antibodies. Their diagnosis, if the patient's a sickle cell anemia patient, I know that I'm probably going to be looking at a serologically complex patient because they make antibodies hand over fist. Transfusion and pregnancy history, this is especially important if you get a positive screen. The 2 ways you are exposed to red cell antigens that you do not possess are through transfusion and pregnancy. So if you get a positive screen, first thing you're going to do is get this information. Special patient needs, for example, do they need CMV negative? Do they need irradiated blood? For immunocompromised patients and cancer patients, these are the 2 populations that get this type of blood. And leukoreduced blood is considered CMV safe. But some physicians may want an actual serological test to confirm it's CMV negative. If the request form has any errors in it, for example, the information is incomplete or lacking, they have, this has happened to me a number of times, instead of having Thomas Smith, they have Tommy Smith. I'm sorry, that's not his given name. That's not his legal name. If it's inaccurate, they requested, I don't know, 10 units of packed RBCs, and you know this patient, based on their hematology results, they definitely do not need 10 units of packed RBCs. And this is where you need to start applying your knowledge, get out of your bubble, and go into other departments. Because hematology is our friend. Coagulation department is our friend. Because a lot of times we can get information from them that will help us in determining whether an order is accurate. Do we call the doctor and say, is this what you really meant? It just depends on your facility. Most of the times, either the supervisor or the pathologist will get involved in that. If the request is illegible, if I can't read it, no, I'm not going to do anything with it. I will very tactfully call the doctor's office or wherever this order came from and say, I'm sorry, I cannot read this order. Would you please send me one that I can read that is legible? Specimen requirements. The testing performed is only as good as the sample submitted. So I've done the perfect ABOD type, the perfect antibody screen, the perfect cross-match, but it was on the wrong patient because the sample was mislabeled. It may as well just go in the trash. A properly collected sample from the correct patient is critical to safe blood transfusion. The patient must be identified with 2 identifiers, and it's really best in a large acute care setting to allow properly trained individuals to collect these samples, and they should be competency assessed once a year. Labeling, the minimum is the patient's full name, some patient unique ID number, usually the medical records number, sometimes the date of birth, the date and time of collection, although some institutions require the date only, but most large transfusion services also require the time because samples can only be used for a specified amount of time. And the phlebotomist identification, their initials. And on occasion, a sample was delivered and there were no phlebotomist initials, and they would come in and beg me to let them put their initials on. I said, no. As soon as you left that patient's bedside, you broke the chain of custody with that sample. And I'm sorry, rules are not made to be broken. You will need to go recollect it. Yes, I know it was the toughest draw that you've done in your life, but you must go do it. My biggest horror story is my first job was in a very small hospital, I don't know, 60, 70 beds, and I received a cross-match order for a patient. So I went and collected it, verified their name, their ID number from their bracelet, went back to the lab, I typed them, they were AB positive. Well, in our little bitty transfusion service, we didn't have AB positive blood. I had to special order it. So in the meantime, another cross-match came for the patient in the next bed, and my colleague went and drew that sample. And remember, I wasn't even graduated yet. Back then, you could work in a lab without having the credentials. I was a medical laboratory scientist student in my last year. So I typed this patient, and they were AB positive. I'm going, oh my gosh, isn't this cool? 2 patients in the same room who are AB positive. And so I ordered that blood from the blood center. Fortunately, they had a very, very smart doctor, and he said, I do not believe this. I want both of these patients redrawn. Sure enough, my patient was AB positive. The other patient was O positive. So if they had been transfused with AB positive blood, they were doomed. So again, rules are not made to be broken. Follow them each and every time. Many times I've walked into a room and the patient did not have an armband physically attached to their arm. It was attached maybe to the bedside table or to their bed rail, and that is not acceptable. They play musical patients all the time. They'll move a patient from this room to that room to that room, and their identifier will stay behind on the bed or the bedside table. If the armband is not physically attached, you will not draw the patient. You will tactfully ask the nurse, would you please band this patient so I can draw their blood? Sometimes you may want to look on their ankles, because if they've come back from surgery, sometimes they'll remove the armband from the wrist and put it around the ankle. Again, you want to have a qualified healthcare provider band the patient. In an emergency situation, the emergency protocol must be followed, and each institution will have their emergency protocol. In the emergency room, the patient identity may be unknown, so you'll need to use a temporary ID. At our facility, to make it very apparent that the patient's identity was unknown, they have these kits for unidentified patient. This would be Donald Duck. This would be Mickey Mouse. They're just names that are so out there that it's obvious it's not the patient's real name. Of course, in this day and age, maybe somebody named their child Mickey Mouse. Who knows? But just know that there are protocols. In pre-admission testing, that means the patient is going to have the testing done before they're admitted to the hospital. You have to stress to the patient the importance of returning with their ID band, or we'll have to start all over. And most facilities, the large ones, will have a special blood bank armband, and that one must remain attached to the patient. And if it's not, like I said, if they're admitted and they don't have this, we'll have to start over. The sample must be labeled in the physical presence of the patient, just like any other sample. And most facilities are now moving to have the patient verify the labeling on their sample. These are examples of 2 commercial armband systems that may be utilized in addition to the institution armband. So the institution armband is the one that you rely on as one of the identifiers for the patient. But this one is a separately labeled. You label it with, you write the patient's information, the date and time of collection, your initials, and you see all the little barcode things. The mother bracelet goes on to the patient. Then these little stickers will go on to the units of blood that are cross-matched. And so there's a barcode reader, so when they bring that unit of blood to the room to transfuse, they'll scan the barcode on the unit and they'll compare it to the barcode on the patient. And so this is just one additional step, because unfortunately, acute hemolytic transfusion reactions resulting in death still occur. So what are the sample requirements? You want to draw it to a stoppered tube. You may use serum or EDTA plasma. That will be determined by your institution. You can draw from IV lines as long as proper protocols are followed. And this would not be you. This would be a licensed person, a nurse. And I still don't feel comfortable with it. And what they're supposed to do is go ahead and stop the IV, allow the blood to go for about 10 minutes, draw the sample, and then turn the IV back on. But most nurses say, yeah, I can't, I have a 50-50 chance that my IV won't clot off when I do this. So it's preferable just draw from the opposite arm or draw below the IV. Samples cannot exceed 3 days if the patient's been transfused or pregnant for the last 3 months. Put a huge star by that, or note it in the notes you may be taking. I'll say it one more time. Samples cannot exceed 3 days if transfused or pregnant in the last 3 months. So the collection day is day 1, and this can be used until 11:59 p.m. on day 3. The sample must represent the current immunological status of the patient. If there are no pregnancies or transfusions in the last 3 months, the institution will set requirements for use. So why we have this requirement is sometimes it takes weeks or months for an immune red cell antibody to become detectable. So if you test the patient too early, just like in most serological tests, like for a recent infection, it may not be present in enough amount to be detectable. So that's why we have this rule. Due to an increase in drawing samples on the wrong patient, it's becoming standard practice in the field of transfusion medicine to collect a separate second sample after the first for patients with no history. So what this means is a lot of institutions have gone to letting the nurses draw the blood, and so they will draw the sample and they'll send it to the lab. And then they are required, if we let them know we have no history on this patient, they have to draw a second sample, a separately drawn second sample, so that we can compare. And this has reduced the number of incorrect collections tremendously, because it's very apparent if their ABO types do not match. Unfortunately, nurses I know they're busy. We're all busy. We're overworked. We're just at our limit. But they have been known to draw 2 tubes at the same time and say one to be labeled as the second draw. And this, unfortunately, has become really prevalent out there. And I don't know ways around it. Rules are not made to be broken, especially in the transfusion service. I would hate to be the person who, due to my negligence, a patient died because I was in too big a hurry. I've seen nurses labeling samples at the nursing station, which is absolutely reprehensible in my book. They just don't get it, and it's because they're ignorant. And I don't know if I've told you the difference between ignorance and stupid, but ignorance is that you've been told something, but you don't know any better when you do something wrong. Stupid is you do something, you've been told this is wrong, but you do it anyway. So really, they're not ignorant, they're stupid. And unfortunately, the patients are the ones who may suffer. Infants less than 4 months old, after initial ABO-D type determined, this test can be omitted during the entire neonatal period as long as the infant receives ABO-specific or Group O cells with a compatible D type. Also, there can be no unexpected antibodies detected, and infants receives no components containing clinically significant antibodies. Then no additional testing is required during the neonatal period. So what this means is that the baby's type is done, and if there's no unexpected antibodies, which the mom will be the best source of doing the antibody screen, and that's what we do. We always do a screen on the mom. And if she has no unexpected antibodies, then the baby is not retyped for the entire neonatal period. Once they reach their 4-month birthday, they become an adult in the transfusion world. Samples for the transfusion service must be verified by qualified laboratory personnel. So that would be me. That would be you, who is ever doing the pre-transfusion testing. If there is any doubt as to the identity of the patient or labeling of the sample, a new sample must be obtained. It's unacceptable and extremely risky to correct incorrectly labeled samples. Each lab will have policies for accepting mislabeled samples. You must be able to defend in a court of law the reason a mislabeled sample was accepted. If a sample can easily be recollected, there should be zero tolerance. So spinal fluid, if it's mislabeled, then there's a protocol to follow, getting the pathologist involved. If it's a blood sample, have them draw another sample. A study found mislabeled samples are 40 times more likely to have a blood grouping discrepancy, which means the types don't match. And one of my colleagues, I thought this was great. A nurse called because they told her the sample was mislabeled. And she begged and begged and begged, please, please, please let me come down and correct it. So he let her come down, and he had a rack, because it was a really big hospital. He had a rack of unlabeled samples. He said, which one is yours? And whether or not that taught her a lesson that stuck with her the rest of her life, I don't know. But I thought that was wonderful. You must memorize the storage requirements. A sample and a sample from the donor red cells, if there's a cross-match, must be stored at 1 to 6 degrees centigrade for 7 days after transfusion. The donor red cells may be the actual segment used for testing, and when you get to compatibility testing, we call them pigtails. I like to call them segs, but they are a piece from the mother donor unit that you use for testing. The donor segment removed upon issuing the unit may be saved, so either the one that's actually used. I prefer the one actually used. You must have a sample for repeat testing if the patient has a transfusion reaction, either immediate or delayed. So when a patient has a transfusion reaction, the first thing we're going to do is pull their sample from the refrigerator and repeat the testing, because perhaps you mixed up samples during the testing process. Storage capacity will many times determine the amount of time a sample may be used. For example, a 3-day sample plus 7 days equals 10 days. So that's what we do for all patients. Is their sample is good for 3 days. We have to keep it for 7 days after transfusion. So by keeping it for a total of 10 days, we'll meet both of those requirements. For non-pregnant, non-transfused, for the last 3 months, they may elect to use for 14 days plus 7, which would be a 21-day storage. So again, we allow patients who are pre-ops to come in ahead of time, and if they've not been transfused or pregnant in the last 3 months, we will use their sample up to 14 days. But again, that means you have to have room to store these samples for 21 days. Compatibility testing must include checking previous records for patients' serological history. So what we have an antibody file, or now it's easy, it's in the computer. The first thing you do when you sit down for your sample, is you look up to see what their transfusion history is at your facility. If a patient has history, you must compare the current results with previous testing results. So let's say 10 years ago the patient came in for a routine cross-match, and now they're coming in for a cross-match for another preoperative procedure. If they were an APOS back then, they better be an APOS today. And if they're not, if that type of discrepancy occurs, it must be resolved before you go any further, because maybe the wrong patient was drawn, and this is labeled with this patient's information, but it actually came from someone else. The most significant information in a patient history is that of clinically significant antibodies. So if they have, for example, anti-Big E was identified the last time they were with us, the specificity, let's say the antibody screen is still positive, whatever specificity they have today should match what they had before. And regardless of the result, it may be negative because now the antibody's fallen below the level of detectability. You must give antigen negative blood for the rest of that patient's life. I want to say that one more time. Let's say that the patient 10 years ago had an anti-Big E, and now today you've done the cross-match and the antibody screen is negative. Even though the antibody screen is negative, you must assume the antibody is still there, but it's below the level of detectability. So for the rest of that patient's life, they must get Big E negative blood, or whatever antigen specificity it is. The serological testing, most important test, of course, is the ABO grouping. And again, everything in the transfusion service, we have a known and an unknown in every test. So for the forward type, we have unknown patient cells that we'll test with reagent anti-A and anti-B. In the reverse or back type, we'll have the unknown patient serum tested with the reagent A1 and B cells. If there is a discrepancy, it must be resolved prior to issuing the blood. In an emergency, you will provide group O negative red cells unless we can actually determine the patient's D type and AB plasma products. Let's talk about D-typing. This involves testing the patient or donor cells with anti-D. The test with anti-D must be controlled to avoid incorrect interpretation. Follow the manufacturer's instructions. And there's 2 times when a D control must be run. One is when the patient is AB pos, and that controls the immediate spin test with anti-D. The second is weak D testing, which that controls the anti-human globulin phase of weak D testing. If problems arise, transfuse with D negative blood. The weak D test is unnecessary for recipients because we're going to base their D type on the immediate spin reaction with anti-D, and they will be considered D negative. Some facilities want to do a weak D test just to get a baseline, but it matters not what the outcome is, because if they are weak D positive, how do you know they're not the partial D? For donors, no weak D test is required to be performed by the transfusion service. We do an immediate spin with anti-D, and that verifies that donor is D negative. What they found is even if the donor is weak D positive, it is very, very less immunogenic than the true D antigen, which is why it's not done. D-typing of D-positive donors is not required by the transfusion service. We'll test them with anti-A and anti-B, but no D. What does it matter if a D-positive unit was accidentally labeled D-negative? Will that harm the patient? No. The weak D test must be performed by the blood collection facility for the donors. And if the weak D test is positive, then the donor unit is labeled D positive. Antibody detection test. The serum or plasma of the patient is tested against a single donor suspension of cells selected to carry blood group antigens necessary for detections of most important, clinically significant, unexpected antibodies. And you're going to get sick of me saying this, and it matters not because it's so important. Unexpected antibodies are those other than anti-A and anti-B. If you have a group A person, they must have anti-B in their serum or plasma. If you have a group B person, they must have anti-A in their serum or plasma. If they do not, that's an ABO discrepancy. A clinically significant antibody, again, memorize this, has caused hemolytic disease of the fetus and newborn, has caused a hemolytic transfusion reaction, has caused unacceptable survival of transfused red cells, and is reactive at either 37 degrees or Coombs. IgG-coated red cells, also called check cells, must be used to detect false negative antiglobulin tests due to inactivation of the Coombs serum. And the most common cause for check cells not checking, for not being agglutinated by the Coombs serum, is insufficient washing. These screen cells are commercially available in either 2 to 3 vials. They're Group O. Why? Because Group O is a universal donor. The following antigens must be present. So all of the common Rh and then the other blood group systems, MNSP, Lewis, Kidkel, Duffy. There's no requirement for low frequency or low incidence antigens. There's no requirement for homozygous cells to be present, not in the screen cells, although it's ideal. And they may not be used beyond their expiration, as some antigens may deteriorate. The type and screen is a safe alternative to a full cross-match. In this particular procedure, you perform the ABO, D, and an antibody screen. When done correctly, this will detect 99.9% of unexpected antibodies. If the antibody screen is positive, the patient is not eligible for the type and screen protocol, and the antibody must be identified, and antigen-negative donors must be selected for the cross-match, and it must be cross-matched to Coombs. If the antibody screen is negative, no cross-match is performed. It's extremely safe and effective, and is most frequently done for obstetrical and preoperative patients where the risk of bleeding is minimal. For example, when a obstetrical patient, a woman giving birth, goes bad, she goes real bad. And we have to have a ton of products ready to go. But 99% of most women in childbirth do not have bleeding issues. And the same thing with cross-match, hysterectomies, tubal ligations. There's a whole host of surgical procedures that there may be a slight chance of bleeding, but 99% of the time there's not. And this is why if you're doing a type and screen protocol, I prefer a 3-cell screen, because that increases the chance of you having more homozygous cells to detect weakened antibodies. If complications arise, the patient can receive ABOD type-specific immediate spin cross-match compatible within 10 minutes. And that's nothing. And we were one of the first hospitals in Austin to go to this protocol. We were blessed to have a pathologist that had our back and fully supported this, because the surgeons were very, very uncertain about this. But again, we promised them within 10 minutes you're going to have blood out the door, and we were able to honor that process. The only thing is the transfusion service must have an adequate stock of blood. So if you have 50 type and screen patients and they're A pos, I'm not saying that you have to have 50 units of blood, but you need to have enough blood. You can't have 0. You can't have 10. You need to have enough that if a patient goes bad, that you can supply the blood that's needed. You must memorize the limitations of the type and screen. It cannot detect all antibodies. The antibody may be directed against a low incident antigen that's absent from the screen cells. For example, the patient has an anti-CW and the screen cells are negative for CW. The antibody may have fallen below the level of detectability, and this is not uncommon. Or the antibody may be exhibiting dosage effect, where it reacts more strongly with a homozygous and weakly or negative with a heterozygous. So let's talk about an example. A red cell which is positive for both alleles, JKA and JKB, is a heterozygous cell. Half of the antigens on the red cell will be JKA positive, and half of the antigens on that red cell will be JKB positive. A red cell which is positive for JKA and negative for JKB is homozygous. For JKA, it has 100% or a double dose of the JKA antigen. So let's look at the next slide. So we have two patients here, patient 1 and patient 2. And if you'll look, we have 3 screen cells, and this is why I love having 3 screen cells. The first cell is homozygous for JKA. How do I know that? It's negative for JKB, so it has a double dose of JKA. Screen cell 2 is homozygous for JKB. How do I know that? Because it's negative for JKA. And then the third cell is heterozygous because it's positive for both. Now, on the bottom, I have an illustration that shows you a JKA homozygous cell, and you see the little purple structures? That shows you that 100% of the KIT antigens are JKA. In the second cell, we see a heterozygous. So 50%, the little blue, are JKB, and the other is JKA. So it has 50% of the amount of antigen. So in patient 1, we got a 3+ with the homozygous cell and a 1+ with the heterozygous cell. Why? Because there was less JKA antigen on the third screen cell than on the first. And the most dangerous situation is when you have a patient with a very low dose of the antibody present in their serum or plasma. So if you notice patient 2, there's a 1+ with the homozygous and a negative with the heterozygous. And with experience, you will learn to question every reaction you get in testing in the blood bank. Because a 1+, maybe it matches some other antigen, but again, if it doesn't match a specificity with any antigen, immediately think dosage effect, that we're having an antibody that's reacting with more strongly with the cell with a double dose, and then negative with a single dose of the antigen. I apologize for this lecture going so long, but I provided a lot of extra details, and but this is the end of part 1.